And Danny, whenever you are ready, you can go ahead and hit start webinar unless we're ready now.
I'm starting. Good morning, those of you who are just starting to join us. Thank you for attending today's webinar. As people join, I'll periodically check in until we have all those who are in the waiting room in attendance. So we'll start very shortly. Thank you. Again, thank you, those of you who are joining the webinar as we speak. We'll be starting in just a few moments. We want to give those who are in the waiting room a little more time to join the conference or join the webinar. So we'll be starting very shortly. All right, good morning. And I want to start us on time, and those who join the webinar as we progress are welcome to, obviously, to join in and participate in today's discussion. My name is Denny Brennan, and I'm the Executive Director of the Massachusetts Health Data Consortium, and I'm delighted, if I can speak clearly, to welcome you to today's webinar with Matt Lambert, the Chief Medical Officer of Curation Health. Let me spend a few moments telling you about how we conduct our webinars and how you can participate actively during the course of today's discussion. We have the chat feature on Zoom. Please enter your questions into the chat feature or into the Q&A. And we will read those questions, we will compile them, and throughout the presentation at moments where we have a chance to speak to Matt, and I'm reminded to please use the Q&A panel. At the moments when we can raise our questions with Matt, we will raise them throughout the course of the presentation. So the idea for us is to maintain a healthy back and forth between those of you who are online and Matt Lambert. Couple of rules of order. One is, if you are using social media, you can see that we have Matt's hashtag as well as the hashtag for Curation Health. You can see at the bottom the hashtag for Massachusetts Health Data Consortium at MaHealthData, as well as, or I should say the handle, as well as several hashtags that we've included at the bottom for Mass Health Data, Curation, MHDC, and value-based care. I'm very excited and very pleased to welcome Matt Lambert to today's conversation. Matt is a physician and brings more than 20 years of experience as a clinician, as a chief medical informatics officer, and a change leader in value-based care, ensuring that patients receive more comprehensive care and that payers and providers better capture the value of their services. Matt is a practicing board-certified emergency medicine provider who previously founded his own physician staffing company. Dr. Lambert was one of the founding members of Clinovations. During his time there, he served as part of the leadership team for several electronic health record implementations at the nation's largest public health system in New York City, the University of Washington in Seattle, Johns Hopkins, Barnabas Health, MedStar, which I know well, and Broward Health. He is also the author of 2 healthcare books, Unrest Insured and Close to Change, Perspectives on Change in Healthcare for a Doctor, a Town, and a Country. Matt, thank you for joining us today. It's a pleasure to have you with us. Please tell us a little bit about yourself that I haven't covered, and we'll start when you're ready to walk through your discussion.
Well, Denny, thank you so much for having me. Thank you for reaching out. I think it was late last year when we set this up. So looking forward to a discussion today. The slides are sparse, as I tend to make them. So and that's going to drive us to a conversation. So I want us to make this as conversational as possible as we go through it. And Lynn and Denny, when I go into presentation mode, because I'll drive my own slides, I can't quite see the chat as well sometimes on Zoom. So please let me know when we need to do that. As far as intros go, Denny, you nailed it. It's a lot of that work was done through our firm called Clinovations, which came together when and I don't know if it's intentional, but when the Meaningful Use Bill and then the Affordable Care Act all kind of came together, we decided that we were going to ensure that this had as much clinician influence on it as it could. And that's led to opportunities around the country. And it's just been, an amazing ride. Clinovations then became part of the advisory board. The advisory board is now Optum. And Curation Health is a little more towards our, Optum does a lot of things. Optum doesn't move fast. And a lot of us at Curation Health like to be able to try and influence this at a certain pace. And so a lot of us who were previously with the advisory board have kind of regrouped at Curation Health to really help drive value-based care with services and technology. Because, Denny, we were talking before we turned it on, a lot of this needs machines to make it scalable or to drive it. And the parts of this that are rote and the parts of this that are repeatable processes, right? We need to do as much of that as we can with technology, and then allow humans to really do the human touch part and the interventions around that. So, having said that, I'm going to go ahead and grab the screen.
Okay.
Team, let me know when we can see, and I will start the slideshow from here.
We are seeing you loud and clear.
All right. Fantastic. So the framing this up, and again, I'm excited for this to go any way that's going to best serve those who are spending their time here. But really, just value-based care. A lot of this has become cliched. A lot of this has become buzzwords, and so really talk about what we're trying to do with value-based care, and the really specific. Seeing how I'm speaking, with the Health Data Consortium. We'll talk a lot about some of the really specific data needs that you have to do value-based care very well, and how often how challenged delivery organizations are to manage this data. And then we'll talk about the current state of where the value-based care market is now, and we'll talk about what comes ahead. And I was reviewing this again, Denny. I kind of put this together. When we first talked about it, I framed it up, but there's been so much movement, especially around the DCE. I don't know if all of that drama, I'll call it, has made it up to Boston, but it's certainly been top of mind in DC about a lot of the changes there and what that might mean for the future of value-based care as well. So that is how we'll frame this. Denny did a great job on the introduction, and I kind of added to that a little bit more. So we'll talk a little bit less about my background here and a little bit more about just the why here. So the technology and services to assist organizations adopting value-based care. One of the things at the advisory board over a decade ago now, we created a tool that we built within Epic and Cerner at health systems across the country to really help providers adapt this specifically around certain diagnoses around HCCs. And we'll talk a lot about HCCs and talk a lot about risk adjustment. But we learned so much through that experience that we founded Curation Health based off of that product at the advisory board. And really, it's taken advantage of what has changed in that decade. The APIs have come into play much more, even though they're still not as prominent as you might hear or as you might think. Some electronic health records have very robust APIs. Some are still working on them. And also to have and we used to build that each time in each different instance, relying on either electronic health record resources or health system resources who are already strapped, already have day jobs, already have more than enough on their plate. So the ability to develop our own technology and our own team to really do a lot of this is what's been new for me, I guess, getting into this part of value-based care and healthcare data management. And Janice and I we were talking again before it came on because she was talking about some work that she's doing to help cleanse some data so you can get some use out of it. And we have a very talented team and we have very cutting edge technology, but still our team just spends a lot of time wrangling data. It's really remarkable to see that we're still in that current state. So enough on that. And we'll go into some headlines here. Population health, value over volume, the triple and quadruple aims. I'm waiting for the quintuple aim. We'll see when that comes. And then also,
it's inevitable, Matt. We're going to have a fifth one, I'm sure of it.
Yes, yes. And then also the value-based care is kind of, and especially with a lot of the changes recently around the direct contracting entity work, it's kind of falling into two lanes of a public lane and a private lane. And we'll talk about all the kind of the good and the bad that come with that. But population health, is probably, when I talk about cliches and buzzwords, that's probably the first one that's kind of become even a little bit diluted. And so when you think about healths of populations as opposed to health of individuals, and you think about managing those from a holistic way, and often in a way that is a payer entity, a provider entity, or a new term, a payvider entity, right? A payer-owned group looks at takes responsibility or risk, depending on your outlook, for the outcomes of this group, of this population, and risks in outcomes, risks in cost, and risks in utilization. So it's really a different way of doing it. And my favorite part of population health or value-based care is it gets you out of the actions you have to do to get reimbursed, right? And fee for service, I have got to set up a certain thing so I can drop a 99213 every time I encounter a patient, and then that drives patients to at least pre-pandemic to come into the office, and I engage that patient a certain way. I document that care a certain way in order that gets me that I'm going to get financial credit for that. There's usually either some lab test, some imaging test that comes out of that, and then we swipe the credit card and charge for that transaction. Population health gets you out of that. It gets you out of the, you can engage patients in ways that's going to get the best outcomes without being tied to the reimbursement model, and we're going to talk a lot about the per member per month, the per member per year reimbursement model, or I've started saying that the subscription model. I was given a couple of talks last week, and it was the same week that my Netflix subscription went up and my Amazon Prime subscription went up. So people really kind of can understand that I'm, the way that paying for healthcare on a subscription model is really a novel concept. But much of our economy, much of our digital economy is going that way. And I think it only makes sense that our healthcare economy will go that way. Value over volume. This is another one that's become diluted. I was in med school a long time ago, and at that point, that we were told that 40% of what we did was based on evidence, was based on scientific evidence. And I don't know, maybe it's 50 now. I don't know exactly what the number is, but a lot of what we do in healthcare is based on anecdotes, it's based on our training. We're really beholden to our training in healthcare. And a lot of it is habits, or a lot of it is driven, as I was talking, by a fee-for-service model. So with value-based care, you're really trying to how should I say it? Be more efficient in your actions and make sure that it's tied to ones that really get the best outcomes. So that's why there's a large quality component to value-based care. There are always certain quality metrics for those things that we can prove with evidence. Those actions are incentivized with scores, star scores, HEDIS scores, or sometimes with even shared savings, or sometimes just real dollars to incentivize certain behaviors, healthcare screenings, cancer screenings, breast, colon, different management around diabetes. So it's trying to drive us to things that are really proven and tied to evidence that can change outcomes, as opposed to just trying to crank out one more patient, or, in my panel on a Friday afternoon.
Now we have a question, Matt.
Yep.
Do you see population health and value-based care as interchangeable terms? I mean, is one the economic model and one the sort of population medical model? How do we look at those differently, or how are they tied together?
Denny, I use them interchangeably, for right or wrong. I think they're pretty tied together at the revenue model. I have a slide, that says basically, if you want to change healthcare, change the way you reimburse for it. But no, I think I use them interchangeably, for right or wrong. But it's just a different way of looking at the way you're caring for groups of patients, and the different incentives that come with that.
Okay, thank you.
Yep, thank you. Triple, quadruple aims. So we started down this journey over a decade ago now with talking about improved outcomes at lower cost and a better patient experience. And patient engagement is a different. Proactive outreach and proactive care is a very different part of value-based care or population health, to patients who are at risk for adverse outcomes, reaching out to them directly and engaging them, whether that be through outreach, whether that be a phone call, whether that be for telehealth, whether that be through engagement through an app, push notifications. So it's been a big push to improve this outcome. And it's sometimes I'm not sure that you can get engaging patients in ways that they're engaged in their other lives, the rest of their lives around consumerism. Sometimes I think that we can over rotate on that a little bit, but patient engagement or the patient experience is always an important part of the triple aim or of any population health initiative. And then the quadruple is let's think about the providers too, right? And this and I don't know, Denny, if this was this was part of the language before the pandemic, but I think certainly during the pandemic, I think we've really gained a new appreciation for the provider experience as well, and what we've asked a lot of our providers to do, and kind of what we've I don't know, given them a lot of mixed messages, right? I mean, they were clapping for us at one point on the provider side, and then I think as a lot of fatigue has come around, we've kind of moved on from really giving the providers their due through this.
Right, and we did find for some providers during the earlier stages of the pandemic, the first surge or two, I don't know how many surges there have been altogether. I think there have been 3. That being in value-based care arrangements and at-risk arrangements with their health plans softened the economic impact for practices versus those who were more steeply invested in fee-for-service medicine. So I don't know if that persisted through the pandemic or not, but there's certainly a lesson there around. It's nice to be paid for care. It's difficult to manage care against that budget, but there are some benefits outside of just the population health benefit that provide stability for some physician practices, I'm sure.
No, and that's a great point. And what's one of the challenges to adopt value-based care is you've got to have an 18-month view on it, really. If you're going to pivot your entire practice or your entire health system, you're not going to see the benefits of that for a year and a half. And health systems aren't built that way. A lot of them are running on a 2% margin, relying on heads and beds right, for revenue. And the other piece is during the pandemic, we had people stayed away, and the acutely, the very ill were seeking care with often protracted hospital stays, right, with some long COVID cases. And that's not how this thing is built. That's not how the fee-for-service system is built. It's meant for turnover, and it's meant for procedural care, right? That's where most health systems. Ambulatory care is a large revenue driver, but it's a push. And then the main driver is some of the procedures, orthopedic and cardiovascular procedures primarily. So when the healthcare system got hit with fewer numbers but higher acuity, that's just not how it was designed. So I agree, the payers certainly did well. The subscription model payers certainly did well, but also value-based care or subscription model providers also weathered that storm better. And it allows you to look a little farther down the road. And so I think we'll find at the end of the day, the pandemic is going to be an accelerator of value-based care and of the subscription model. And then public versus private is an interesting piece too. And here I'm talking about Medicare Advantage versus the ACO model. And it falls kind of how you would expect when you're sitting in either of those two chairs. If you are a private equity or venture capital backed Medicare Advantage entity, you want to you're going to think aggressively. You're going to have a high risk tolerance. You want to reward performance, both clinical and financial. And then the public side of this is the ACOs, which are going to have performance caps, which are going to be more conservative in how they approach the revenue model. The recent shift in the direct contracting entity from CMS was really leaning heavy on the private side, and they found that the new administration came in and saw that there are a lot of those administrative layers that you have to create a direct contracting entity or private equity firms. So they purposely switched it back to incentivizing those to be run by providers. And also to have a focus on social determinants of health and health equity. So it's interesting when in DC, and Lord knows I've probably been there too long. But when you talk about value-based care, often the regulators and CMS has one view of it, but make no mistake, the private groups are leading this, and they're driving it, and they're way out ahead of the public side in adopting this and coming up with new models.
Well, we see in Massachusetts, for example, with Blue Cross Blue Shield is one example, that they have the alternative quality contract, which has been quite successful. It's a physician model. It's not, they're working on doing the same for hospital facilities, but the value-based arrangement, that is the alternative quality contract, is done quite well. And it's an example of the quote unquote private sector, albeit Blue Cross is a not-for-profit, engaging physicians to manage, with greater evidence-based discretion, I think is the term I heard recently. Yeah. But a question comes up, we could probably get pretty good at managing, what's under the bell curve up to like one standard deviation. But when we get out on the edges, we have a lot of people who don't fit into these models very well. Can you comment a little bit about how value-based care can address those who fall outside of that 80-20, the ones who are in the 20%, that may not get the benefits, or we have to do something special for them? How does that work?
Well, that's where the patient engagement piece comes in, right? Proactively reaching out to that group in whatever way is going to be best suited to them. I would love to see some of the psychometrics of practices of our social media platforms. I would love to see that applied benevolently to patients. Maybe someone might respond better to a challenge. Someone might respond better to knowing that their neighbor is, their A1C is, under control. So I think there are a lot of ways you can use technology to reach out to them. But that's also, Denny, where SDOH really comes in my mind. Social determinants of health and investing in that as either a payer, and the payers are, are best beneficiary of these investments. But reaching out to those outside of on the edges of the bell curve, and really investing in their lives in ways where the health benefit's going to come back around over time. You know, and I'm talking about ride sharing to you know, make it easier to get to the clinic than it is to dial 911. I'm talking about home food delivery, maybe even paying rent. And so and a fee for service entity would never want to do that. You know, the joke, and it is, you know, a fee for service system would rather fix your broken hip than repair the sidewalk that you just fell on, right?
Right.
But when you think about those on the margins, a value-based care model allows other investments and really outside of the normal way of thinking of delivering healthcare, but it allows engagement of those and investments in those folks, and investment in communities that maybe haven't had investment in a long time.
We have another question from our friend and colleague Ferris Taylor, who asks, how does value-based care move upstream from acute and chronic, you know, the classic high fee-for-service healthcare, to longer-term improved consumer behaviors, healthy behaviors, you know, diet, exercise, keeping up with your immunizations, your, you know, behavioral health, managing the social circumstances within which people find themselves, the social determinants that you mentioned. Could you talk a little bit about how we move from the acute care episodic environment to that longer term population actively involved in maintaining their health, managing their risk for disease, et cetera? How do providers keep people from coming back? That's the ultimate value-based care model, is you've done as much as you can at the time you have the patient to make sure that everything that causes that, you know, risks to their health is addressed, the patient is equipped. How do we do that? How does that happen?
Looking at the public versus private line, Denny, I think my first answer would be downside risk, because that makes you adjust your operations to that model. That makes you adjust your management style to that model when you've got skin in the game. And I base that on an article in Health Affairs, and that's probably 3 or 4 years ago now, that said you can be a large IDN, a large health system, and you can have 20% of your contracts in a value-based care arrangements, and not change your operations and still do well with your revenue. You have to go to 2/3. You have to go to 2/3 of your contracts to be in value-based care with downside risk, with the skin in the game, to make value-based care your primary, to be viable again. So there's this 20% to 63% no man's land that the only people who enter that up until this point have been in-home primary care, full risk, totally embracing that model. You see a couple health systems who've had this baked in. I mean, what we're doing now, Kaiser's been doing it since the 70s. Geisinger in central Pennsylvania, basically they manage everything between Philly and Pittsburgh as their population. And they've done a lot of this, but the way they've they aligned themselves with the payers. But yeah, the way to make it happen is to embrace the model. And so there's a slide that says we're kind of stuck at about that 20% mark, because that's how much risk you can take on, or how much value-based care contracting you can take on, but you don't have to change anything. And it's really so I think we go there by jumping in. There's no, you know, dipping your toe is not getting us there. We're going to have to jump in the water to do that. And some places are doing that, and they tend to be smaller and lighter and faster, and that makes sense. But a lot of the large organizations are having a tough time. I'm going to go ahead to the next slide. This is my shameless book plug slide, Denny.
We welcome those shameless plugs from our invited guests.
But no, Paul Starr's book is foundational to this kind of thinking. And I think it and in preparation for this, I went ahead and he did an epilogue, you know, added on just kind of what's changed, and the take home was really nothing's changed on that. But and then my book, Unrest Insured, just kind of goes back into the maritime history of the insurance model and how, and basically how providing shipping insurance in the 1700s, I don't think, we might want to rethink how we do that when it applies to healthcare in the 21st century. But the take home message for Paul's book and what I dabble in a little bit there too is like, if you want to change this, you got to change the way we're paying for it. And so that's probably the, and so we'll move on from the shameless plug to talk about, again, we talked about, when talking about the revenue model, I think we talked a lot on the subscription model, the per member per month, or the per member per year model that you have for these patients. And it's caused me to say, if I can get the same clinical outcome from a text message, why would I do anything different? If I can drive your medication adherence, if I can improve your behavioral health engagement, if I can make sure you're taking your antipsychotic medication, and you don't decompensate and engage healthcare in the most expensive ways, then on a subscription model, you're free to do that. You're free to, some patients are going to benefit from a brick and mortar visit. Some might be fine with telehealth. Some might do well on RPM. So the subscription model really frees you up to meet folks where they are. Shared savings is kind of the public side of this, the ACO model. If you meet certain behaviors around quality, let's say, then the shared savings is split between CMS and the providing entity. So that's another good driver for, some folks call it shared savings. On the public side, that's called revenue. But I don't want to get too far into that. A lot of this is driven by risk adjustment, and risk adjustment is one of the data challenges that are associated with value-based care. There are 65,000 ICD-10 codes. A lot of the world is already on ICD-11. I don't know how many ICD-11 codes there are, but these models look at 9,500 of those. So literally they're saying 9,500 of these diagnosis codes that are attached to outcomes, that are attached to utilization, have more value. That data has more value than the other 55,000. And so any part of a value-based care plan, you want to make sure that you're capturing that risk picture that you're taking for your population. And that's completely different than fee-for-service documentation, which was really driven off of volume. And most of us were trained to do fee-for-service documentation. And risk adjustment is flawed. It's deeply flawed. And any particular way that you want to look at it, it's, some models might be better than others. There is opportunity for fraud. There's opportunity for error associated with this. But risk adjustment, I will say this, the one thing I do know for sure about risk adjustment is that risk adjustment is better than the alternative, which is patient selection, right? We spent a lot of time getting away from denying people care based upon their disease burden, which is such perverse logic. So risk adjustment, in my opinion, and I spend every day looking at this, risk adjustment in any form is better than patient selection, than adverse patient selection.
Right.
Yeah. Quality measures. Again, we've talked a lot about that to this point. The tying the screening measures to those things that are proven to improve outcomes and to lower cost. I think that only makes sense, and that will grow and shift. It shifts quite a bit, actually. That's one of the things that we do at Curation Health is keep track of those changes for the health system. When I'm seeing a patient, I don't really want to know what the latest version from the National Quality Forum is, or what my latest contract is. I just want to know that these are my priorities that make clinical sense, and I can act on those, and we will be rewarded for that, both with outcomes and financially. And then a lot of this is around admission reduction and readmission reduction, and this is where it's really cool too. The hospital at home, the regulations have shifted so much in the last 2 years. The biggest things that were holding back a lot of this stuff was the expectations of patients and providers on how they were going to receive and give care, and then also on the revenue model for hospital at home. So I think we're going to see more and more care provided in the home. Remote patient monitoring is a great way to do this, a great way to kind of get ahead of patients who might be decompensating. But managing readmissions and admissions is always going to be a big piece of value-based care.
One of the questions that comes up in this move to value-based care is that when value-based care models have been set up with independent physicians or multi-specialty physician groups, reasonably large group practices, versus their hospital counterparts, that the physician groups do better.
Yeah.
They're not carrying around this great big asset with them everywhere they go and saying, if you want to have me, you have to have this huge health system that I'm a part of. Can you talk a little bit about, direct contracting is a push away from an institutional way of dealing with population health and with value-based care. Do you see that shift of physicians moving out of the health system and reasserting their position in practices and medical groups so that they can take advantage of these models? Or do you see, the continued consolidation of hospitals, the continued acquisition of physician practices as being a help or a hindrance when it comes to adopting value-based care and population health?
No, it's a great question. And I won't pretend like I know for sure. And I won't pretend like the health system or our healthcare system is that well aligned.
Right.
And historically, you just got bigger, right? That's all you had to do. You didn't have to get better, you just got bigger. And that really drove a lot of the M&A, and you would have these health systems getting bigger and bigger and bigger, but yet getting more fragmented, right? Because the technology and the care models and the care coordination couldn't keep up with the pace of merger and acquisition. And we still see that in certain parts of the market today. I think though, I've heard this my entire career, but I think we're accelerating the path towards a hospital is going to be a place to go when you need a procedure with anesthesia or ICU level care, and everything else is going to be done outside. I really think that. Now that's a big shift and it's really, especially in rural areas right now, where you're not only a provider organization, but you're also probably the largest employer in the county. And I just don't think that is tenable moving forward. I don't think you can't be both. You can have really good care, or you can be an employer. But I think all of this is going to move outside the hospital. I think hospitals get smaller. And when I think of like some of these mammoth hospitals, I mean the clinic, right, in Cleveland, I mean it literally takes city blocks. Barnes Jewish in St. Louis, it's massive,
Right.
and wings of it sitting empty now. So I think we're just going to have to move away from that a little bit. And I think the providers are going to go at risk, move outside, and hospitals become solely for acute care.
And those services, hospital services, will be increasingly bought on the margin by providers who are at risk,
Yes.
looking at whether or not that is the best course of care for their patient and what their patient needs.
Yeah. It's just funny. The competition for good surgery spots is one of my. It's comical sometimes at health systems, right? Everybody wants their everybody wants their OR time on Monday morning so they can get all. And so I can see a whole shift in that, Denny, on how people would negotiate for OR time, right?
Right.
Based on those models. On the slide here, we talked a lot about patient engagement. We talked a lot about telehealth, and so I'm going to focus here. But hold on for telehealth for just 1 second, because a margin on a telehealth visit is made for value-based care. And I'm here in Florida. I'm in South Florida. I'm at the Vive conference now, and so this is where a lot of this stuff is really is on the leading edge of this. And like ChenMed, a large private Medicare Advantage organization, they do one in-home assessment early in the year. So have a physician assistant, a nurse practitioner come to your home, do a health assessment for you, do a living assessment for you, and then they do a monthly telehealth visit for the rest of the year. So unless you are so you have someone comes to visit you, addresses your clinical and social needs, And then they keep that patient engaged with telehealth, and they don't charge for any of those services throughout the year. Again, remember, they're on a subscription model. And then there's only in those telehealth visits is if there's a an acute need evolving, then they'll reach out to you either in their home visit or a brick and mortar visit. But so I think just telehealth is just going to play a bigger and bigger role in value-based care. Team-based care is another piece of this as well. Doctors are, we're taught to be quarterbacks, right? And maybe we should probably a part of our training, we should be more coaches. And I realize I'm talking to folks in Massachusetts, about quarterbacks and coaches, which is kind of funny. But the value-based care really puts an emphasis on team-based care. Everyone working at the top of their license. If a nurse practitioner can manage this problem, then perfect. If a physician assistant can manage this problem, then that's best suited. And then you're using your most expensive resources for those things that really need that certain level of attention. But mostly, since for today, really want to focus on the next couple slides on just the data and information challenges around this. It makes health systems who are not good at managing data, it makes them manage information in a certain way. And the anecdote I use here is, if you want more efficient care and better information sharing, you have to make it easier to access that information than it is to acquire new information. Or, stated another way, you've got to make it easier for me to get the result of that CT scan 3 days ago done across town than it is for me to click on another CT scan in my electronic health record. And strangely enough, sometimes it's a whole lot easier just to order new stuff than it is to spend the time and effort to try and find other clinical information. And clinical information sharing not only has a lot of clinical outcomes, but it also drives a lot of the risk adjustment that we're going to talk about. Obviously the quality measures, and also the utilization measures. Again, I can do a CT on you every time you come through the door, if that's the easiest thing for me to do, as opposed to get other information. So the next couple slides, we're going to go deep on data and ways that value-based care makes you think about it differently.
Bob Dichter has a good question. He says, where does technology really play the role in enabling providers to be successful? We have electronic medical records, but they're not really designed to help providers manage value-based care. They're really order entry and database management systems and billing systems wrapped into one. Practices don't have other software or other tools. And they have telehealth. They've invested in a telehealth platform, probably. Some might be using remote patient monitoring, but these are probably necessary but insufficient to really giving a provider a view on, how well is my patient doing? How much of their budget have they used up? What are the the likely next steps that patient is going to need help on, and what tools can I use to help them? If you have any, share with us some of your thoughts about how do you equip a physician, a practice, a medical group, even a hospital-based one, with the kinds of tools that would allow them to go from order entry to patient management. I know this is part of your business, but at the same time, it's a pretty fundamental question. What does a value-based care tool set look like? How do I go from my EMR, which I think is, and as a physician, is the only system I want to interact with if I have to interact with one. How do we embed population health management, value-based care into that kind of environment?
Aside from making this a 2-hour commercial for Curation Health.
I know it's a tough question, but I'm throwing at you anyway.
No, it's funny. I think my favorite anecdote here is out at the Armory in Watertown. Athena, one of the founders, Ed Park, is now with Devoted, a Medicare Advantage organization.
Right.
And he looked at me one day and said, he goes, Athena is an awful value-based care tool. And it's like, I just thought that was kind of funny that, the guy who literally built it was complaining about how poor of a value-based care tool it was now that he's a value-based care delivery organization. and they're designed for that. That's what they're designed for. E&M, E&M codes, fee for service output. So getting that information, and we're not talking about really, the care is the same, right? The care is the same. The way you present the care to payers is different, and some of the hitting some of the metrics is a little bit different. So we gather this information, we cleanse it, and again, I'm just using Curation Health as an example for these value-based care organizations. We pull that in because we have developers and we have analysts that a provider organization could never afford, and we get that data presented in a presented way. And then we use our all that experience we had with electronic health records and getting it into the EMR, Denny. You're right. The minute you ask a provider to leave, we spent all that time and effort getting providers to go there. What are we going to ask them to go somewhere else now? So getting getting that information to the point of care in each different instance of each different electronic health record is a challenge, because they're not really incentivized to do that either, right? We stopped short of, and I could talk about interoperability again for 2 hours, and interoperability is certainly one of the main themes here at the Vive conference that we're talking about here. But getting that into the electronic health record is a challenge that we work with each different practice, each different vendor on a way to do that in a meaningful way. So that's that's another thing that's kind of slowing the adoption, aside from the revenue model, the decentralization of the technology. And we stopped short. I joke in DC that we needed, we obviously need another $25 billion to get us where we were supposed to go, right? With the first 25 billion
Right.
that we invested with it. But no, it's part of the journey. It's certainly part of the journey. Is empowering the tools. And at Curation Health, we're retrofitting a lot of EMRs to become value-based care tools. That's one of the goals of Curation Health. Yeah.
Thank you.
Thank you. Again, we talked a little bit about risk adjustment earlier. Not all this information has the same value. It doesn't have the same clinical value, doesn't have the same financial value. These diagnoses have to be tracked and addressed annually. My favorite example of a risk adjustment model is if you have a patient who is unfortunate enough to have a below the knee amputation. If you don't diagnose that annually and document it and get it on a claim annually, then the risk model just assumes that your limb has regenerated and you no longer
have that
disease burden. And that's preposterous, right? That's how we're managing this. And as we get better at risk adjustment, I'd love to see us to take this off the providers and do this all prospectively, and do this, but now we're getting into Canadian models, quite frankly, of prospective annual payments to organizations based on expected outcomes. But so these have to be tracked and diagnosed annually in order for you to have operating capital to manage these patients. So that's just a completely different way of doing this, and tracking what has been diagnosed this year, what has been maybe what has been diagnosed outside of your organization. Especially if I'm on an ambulatory EMR and I have no vision into what happened, across town, or what happened in Epic. So this requires not only data management differently at the point of care within a provider practice, but this requires payers and providers to communicate in a different way and in a better way. And that's really the last mile and Curation Health, I didn't anticipate that we would be the middleware or sometimes even the brokers of these relationships, but we spend a lot of our time doing that, of being the middleware, both the literal and figurative middleware between payers and providers. And if we're going to move this forward, we're going to have to work together and share information in a way that just hasn't historically been done in the payer and provider space. And then also go ahead, Denny. I'm sorry.
I was just going to say, we have a question right up that alley with respect to technology, which is, we don't want providers to go out of the EHR. That's where they've been spending the last 10 years, or however long it's been. It's close to 10 years now, at least at the scale that we currently have it. But do you see, now this we're getting into sort of the interoperability technology here, but do you see a role for example, smart on fire apps in value-based care, where you talk about, you're being middleware and middlemen between payers and providers. Smart on Fire is a tool that allows messaging and outside the EMR, but in the EMR at the same time. It shows up on the screen, it interacts with the EMR, but it asks providers for answers to particular questions or to complete particular forms. We look at that right now as we launch a digital prior authorization prototype. Mm-hmm. How do we use Smart on Fire? Can you talk a little bit about technologies like these advanced API technologies coming out of Da Vinci as one example, Mandel and others who've built these things from the ground up? How do they fit into this idea of interoperability and getting information in front of the physician while they're in the electronic medical record that can, keep them on track with respect to their value-based care arrangements?
Yeah, no, it's great question. A lot of this is we've moved on the submission side. We've moved from RAPs to encounter data. So no longer can you kind of lob this in at the end of the year, which the payers had always done for a long time. So this has to be done at the encounter level. So to your point around any interoperability or any Smart on Fire has got to fall into the physician rights, right? The right data at the right time in the right part of the workflow. And so to do that prospectively, to get that far upstream, we work off the schedule. We have the scheduling APIs are actually some of the most robust because it's relatively simple data compared to some of the other data movements around other Smart on Fire elements. So to schedule off of an upcoming appointment, to use the APIs to look at the data sources to find what has changed, right? What has changed since my last encounter, or what new information is there, or presenting information in a way that's more efficient so I don't have to hunt and peck for it. So that is how we think managing, getting that in front of the provider based off the schedule and a 3 to 7 day window usually prior to that, and pulling that information forward and getting that in the electronic health record is our focus for a lot of this. I think the only thing, and walk in the halls of HIMSS next week and Vive now, though, I just want to make sure that we stay even interoperability, Denny, can get siloed, right? Can get fragmented. So a lot of times in these spaces, it's, whoever has the best marketing budget wins sometimes. But I just hope that we can kind of hone this in and focus this, because this has got to happen. And it would be best if it would happen in a really coordinated way.
Thank you.
Yeah, thank you. And if you, I'm sorry, was there a question or comment?
No, we're good. We're good for now.
Yeah.
More to come.
And when we talk about risk adjustment and we talk about how important it is for this model, but we also talk where there's opportunities for fraud. This is a good example of if I'm not very specific or not very robust in how I'm and how I'm managing these and the tracking of their chronic conditions or sharing this data, you're looking at a 50% reduction in per member per year revenue to manage the cost of this patient. So if I only capture AFib or I don't maximize my risk capture, let's say with diabetes, then we're talking real dollars, real operating capital to manage the risk and to manage the outcome of these patients. And this is an example that we use for an honest. I mean, this is obviously an anonymized patient example, but if you're not managing the data and the chronic condition management in a certain way, it has a real impact. And right or wrong, HCCs are the currency. They're the currency of value-based care. And again, I look forward to the day when we don't ask the providers to do this annually every year, and we can do this at the at the plan level and pay for this prospectively. That would cut costs of healthcare, anywhere between 17 and 15% tomorrow, taking out the transactional management of a fee-for-service bill. But HCCs aren't going anywhere. Risk adjustment isn't going anywhere. And here are the real dollars that I think will show you why. And again, it needs to be policed. It needs to be monitored, but it's better than patient selection, period. Full full stop.
Definitely.
Quality measures. So we talked a lot about quality measures and tying things, evidence-based medicine, incentivizing some of these behaviors. There's so much variance here in contracting, and that's another thing that we do a lot of at Curation Health is if one of our provider partners has 5 different Medicare Advantage contracts with 5 different quality metrics. And to ask a provider to say, oh, wait a minute, this is an Anthem patient, and therefore these quality measures, I need to make sure I'm hitting those. To do that with technology before the visit is a really good use of healthcare technology. We freed up the provider to engage with the patient and to know what their focuses are based on a certain contract, but to ask providers or even provider organizations or even clinics, MAs in the clinic to manage that is absurd. And so to do that with tech and services before the visit is something that we find very, very valuable. But this also requires data sharing in a whole new way too, right? What has been met for this year, what is outstanding for this year, what are the new initiatives, and to get these in front of the providers in a way that they can act on it is I mean, a lot of this is already in the EMR, but man, it's buried deep. And some of it's in payer portals, and payers a lot of times say, well, we have this great portal, we've done a lot of work on this data, we're very confident in it. All we're asking the provider to do is to log out of the EMR and log into our provider portal and find the information. And that's it's a stopper. That's a hard stop. And so getting this sharing this data and also getting it in an actionable way in the EHR is a very big piece of value-based care, and something that we spend a lot of time working with payers and providers on doing that.
Well, we have a good question about that. CMS is undergoing a project to reduce and consolidate quality measures across the industry to only support the most important measures, but have them be more standardized. Are there specific measures you think are most vital for value-based care?
Yeah.
If you were to pick your sort of winners or the ones that comprise that top echelon, what would they be?
Yeah, and the lack of standardization here is maddening.
It is.
Trying to when we build a lot of these rules ourselves, when we're data mining, and we build them off of the federal standard, thinking that, all right, there's one way, everyone's doing this one way, or saying that these are met one way. And there's just been so much. We have to build a complete different rule set for each client because of the different ways that they manage these. So it's maddening. It's maddening. The part around, and it's also, controlling hypertension has been retired for 2 years. But I can't tell any of my providers or payer partners that it's been retired for 2 years. So just of how things constantly change on this. Just judging from our current provider partners now, everyone does the cancer screening. I think it's pretty obvious, right? And so the breast and colon, it makes a lot of sense to continue to screen for those and to incentivize that. Every group we have does all of the 3 diabetes measures. So the yearly eye exam, the kidney surveillance, and the A1C. So I think those not only in return for quality, but also in things that you can act on. I think those are the top 5 that are that we see most providers use and have the best return, in my opinion.
One of the things we saw during the pandemic among practices, and this came out as the result of a study done by an organization called the Massachusetts Health Quality Partnership, or Health Quality Partners, and several thousand primary care practitioners across the state, was that some of the more successful or most successful practices were ones that, rather than take this episodic, come into the office, we'll do one thing for you, if you need an appointment, kind of a demand driven, when the patient wants something, they make an appointment, and the provider fulfills that, and the patient may want something the next week. One characteristic of successful practices through the pandemic was we're going to have the patient for a relatively short period of time. We don't want them to come back. We want to do as much for them as possible during their encounter, whether it's screenings, whether it's medication reconciliation, whether it's a range of factors that could be a benefit for the patient for a longer period of time and spare them the difficulty, especially if they're disabled and have accommodation requirements, spare them the difficulty of this tyranny of piecework coming in every time something has to be done. Yeah. And getting, the practice taking a more forward look at how much can we do for this patient that's important for them while we have them here now, given that we can't go to see them. We don't want them to come back and see us. Can you comment on that? Is that something you see in your work that is one of the offshoots of getting better at value-based care and population health, is kind of getting better at the encounter?
Yeah.
And focusing more on making it an encounter, sort of an Uber encounter, one that covers as much as can be covered for that patient in the limited time that we have to see them.
Yeah, great question. So identifying these patients is one thing, right? And running the chase list, the risk list, whatever a group calls it, of these are our patients who are most at risk. That's the easy part, right? Identifying the patients. Now, that encounter that you just described does not fit into a 15-minute panel for a fee-for-service business, right? It just doesn't work that way for a lot of dyed-in-the-wool fee-for-service groups. So that's why we've seen annual wellness visits are a fantastic way to do this, and CMS has heavily incentivized that to do. An annual wellness visit is very incentivized by the reimbursement model to do that, to bring patients in and do a lot of these activities. Often it can be done by a mid-level provider, right? Or to do this. That ChinMed model I was talking about earlier, do this in the home. Do as much of this as you can in the home during that 1 hour, sometimes 90-minute. Concerto Care does 90-minute in-home visits associated with this. So to do as much of that in one, and that also brings into this really interesting concept of the near virtual visit, a telehealth visit that has maybe a diagnostic component that's not done in the clinic. So either done, again, I picked up my phone a lot on this, but either some sort of remote technology to test an A1C, or a lab test either in the home or maybe at the CVS around the corner, as opposed to coming into the office. So it opens up a lot of these things, and that's when I was talking about embracing the model, right? Getting from that 20% contracting to your 2/3 contracting. All of these things are a part of that embracing the model of extended visits in home, with a multi-pronged approach to a needs assessment and care delivery associated with that. So yeah, the ones who embraced it are doing it well. If you're trying to cram this into a fee-for-service model,
can't do it.
Can't do it.
Right.
It is humbling now that I've crossed a certain age. I get a lot of push notifications for immunizations now, Denny. That's been a humbling part for me personally. But
it is a humbling experience, but it's an unavoidable, inevitable experience if you're lucky.
Right? Yeah, but I get but it's been interesting now to kind of cross over and get my certain notifications on my phone for my health maintenance. But it's all part of it. It's all part of it. And I think it's if we're going to get good at value-based care, and if we're going to grow it, that's the way it's going to happen. But yeah, great question on the comprehensive visits. Love it. Yeah,
we have another question with respect to, can you comment on how social determinants of health and value-based care would actually work together? I mean, there's some intuitive sense that people who are adversely affected by social circumstances and economic circumstances are going to have a much more difficult time accessing healthcare and being treated for the range of conditions that they may be more prone to or more affected by. Can you talk a bit about, if I took my value-based care capacities and then I weighed those with social determinants of health, what the impact would be? How would I, you talk about looking at the pending visits and people who are going to be coming into the office who you want to understand from the scheduling system may have particular needs. How does SDOH fit into that?
Yeah, I love the SDOH concept. Part of it, and quite frankly, part of it has come from dilution of risk, right? Once the payers had all the risk, now they're sharing some of this with the payers, or excuse me, with the provider organizations. While we're looking, and a lot of this is how do we put some of this risk off on other parts of the community? Quite frankly, the cynic in me, that's the way I look at this a lot. But I'm going to go back to this slide right here, and I'll focus on just use this as an example, because SDOH investment and SDOH care is going to lag value-based care, in my opinion. Making SDOH investments on their own has always been foundation work and charity work, right? It hasn't been tied to the delivery model or the reimbursement model. So let's say that we have our patient here, and I'm just going to minimize my Zoom screen. We've got $13,000 per year to manage this particular patient who has AFib and kidney disease and emphysema and is on oxygen and has advanced kidney disease. Let's take a piece that I wrote a piece last year that got picked up on this. I honestly likened this to a hedge fund mentality. So let me take of that $13,538 that we have to manage this patient's care for the year. Let's take 80% of that and know that it's going to require that work for ER visits or for other costs of care for this particular patient. But 20% of that, let's take 20% of that and invest that in a way that is not necessarily directly related to their care. So 20% would be a Meals on Wheels program or a home delivery food program for this particular patient here with diabetes. It would be care management directly related to their kidney disease, making sure, something as simple as having to go out and get a new oxygen condenser can drive costs and outcomes associated with that. So when I and just bringing it back up to a high level, in my opinion, social determinants of health investment is going to lag value-based care, because that's only in value-based care are those incentives baked in. But I think investing per member per Y operating revenue in a different way for a particular patient is where it's going to go and where it makes sense. Does that make sense, Denny?
Yeah, it does. It does make sense. I mean, it has to trail.
Yeah.
Because you have to have the value-based infrastructure in place for that to be part of how you manage and how you manage the premium dollar. But it's and when you look at patients such as the one who is represented here, in screening this kind of patient in advance, it's probably pretty likely that this patient's getting to the hospital is a pretty difficult task.
Yeah.
You look at this patient and say, this patient is probably someone who would value having more services available for them at home. They may not be care services because of how severe, how acute their condition is, but they may be able to offset some of the difficulties that patient encounters because of their transportation difficulties. Yeah. Or their disability. I mean, this is clearly a patient who is end stage renal disease or late stage renal disease is going to hobble them considerably, and the more that they can have delivered for them at home, even if it's like you said, even if you trail the clinical encounters and the things you try to do to manage this patient's condition, and you're able to manage those, taking some of that remaining premium dollar that you've been allocated and saying, we need to invest this in the kinds of things that are going to make this patient's life easier, not force them to put themselves at risk trying to get care. It makes a lot of sense. I think you have to know where they are before you can offer the services that they need.
Yeah. No, well said. And I think of like home medication delivery for this patient too, right?
Yeah.
If you're trying to, medication adherence for a lot of these is the best predictor for outcomes. And to have this patient, or who knows, maybe their grandson, right, is the one who may or may not get down to the drugstore to get these items for them. Or in that similar analogy where I said we have for providers, we have to make it easier to access information than to order a new one. What's probably the best transportation alternative for this patient? 911 is probably probably the best transportation alternative. So a lot of those, it's managing those parts of it with a certain part of that per member per year revenue is where I think S2H fits very well into the future of value-based care.
We have another question. If the payment remains the same regardless, your budget, you have a budget for a patient or for a population, how do you ensure that high-use patients are allowed or able to get all the care they need if the nominal cost for them exceeds that what's been assigned to a patient as part of the budget? Do you make it up on the other side with patients who are low utilizers? Is that how this works, so that you're able to accommodate the needs of patients who fall outside of and have greater needs than the ones who fit under that bell curve?
Yeah, well, and here the Pareto principle and all the derivations come into play. 20% of your population drives 80% of your costs. I've heard that, some say 10% of the population drives 50% of your costs. So who these are, and you also make up that for patients who are in a different part of their health journey. But it also, this is also to make sure where this data management and documentation becomes very important, because if I am capturing all of those conditions, it drives up my per member per month budget for this particular patient simply by data management. It's data and documentation management. And so it's again I think having the provider do this encounter by encounter is hopefully, I can't wait till we're moved past that. But this is how your revenue or your operating revenue or capital for this patient is driven off of how well you document the complexity of the care that you're providing. So it's a little bit of both. It's population health dynamics of who drives your cost, but it's also data and diagnosis management, which is an odd thing for a healthcare system or a provider organization to do.
Right. Thank you.
Yeah. No, absolutely. And then let's see. I'm going to do a time check. We're good. All right. And then, so again, utilization data, the ADT data, admission, discharge, and transfer data is some of the most straightforward data to get. Some of the information blocking pieces really require sharing of this. A lot of primary care providers now, they get a notification whenever one of these codes drops on one of their patients, and some organizations, really progressive ones, get it in real time. So managing where your patients are engaging the healthcare system is a new piece of this, where you have to manage that in real time. Referral management is foundational to any ACO or to any population health initiative. And sometimes you even see referral triage, right? To make sure that the referrals to specialists are often necessary. Sometimes they're not. They're always expensive. And so managing these referrals and managing referral patterns and seeing this data and seeing how your providers are interacting with one another in the care of the population is always a important piece of this. And then again, I've come back to the imaging results. If you're dyed in the wool fee for service, you don't want to do this. You don't want to share imaging results or imaging. You just want to order a new study each time. And I think that's managing admissions, managing the ADT, managing referrals, and then managing how you share the information on the work that you've already done is foundational to controlling a lot of costs in value-based care. And again, systems aren't designed this way. Epic's, pardon the sirens in the background, Epic's Care Everywhere is probably the most robust HIE in the country right now. A lot of the HIEs lost a lot of their funding over time and aren't necessarily a point of emphasis. And Epic reinvests in their product more than anyone. And you can set these up with provisions where patients agree to share this information across Epic shops, across a region. We did this in New York City. I know the Bay Area and San Francisco has a very robust HIE internally built within, but sharing this kind of information across populations, across provider organizations, through EMRs, who sometimes are incentivized or not to do it, is another way that I think that data management and data sharing, information sharing, becomes foundational to value-based care.
Have you seen a difference, Matt, in the quality of care since ADTs went into effect? We went statewide in Massachusetts a few years ago. And, the hue and cry about getting ADT messaging across the system went down.
Yeah.
But we don't know if it's actually improved things or not. In your experience, have you seen that kind of real-time messaging coming to providers about their patients with respect to hospital visits, admissions, discharge transfers? Do you see that having a measurable impact, a real impact in the quality of care that these physicians are able to deliver? Or is it just more information gathering?
I'm gonna rely on a real life example here. Still practice part-time. And I often practice on weekends because when I'm not doing my work with Curation Health. And so, historically a patient would present themselves to the emergency department. You do your evaluation and you make your disposition of whether or not the patient's going to be admitted to the hospital or discharged home. And if you're going to admit the patient or set up follow-up, a lot of time that involves a phone call to an on-call provider. With ADT sharing, I'll come out of the room from evaluating a patient. I'll order the diagnostic test that I need to order, and the clerk will say, Dr. Jones is on the phone for you about to ask about the patient. And so I've got proactive outreach for value-based care organizations asking me, what we think the plan might be. And with the new incentives to do a lot of this outside of the hospital, Denny, then it plays a real role in, if we're going to admit somebody for IV antibiotics, well, let's set that up now and let's send them home and have all of that done at home. So for me, real time in my clinical practice, I've seen it change care and change the cost of care. I think it's very valuable. All right. So kind of moving on from some of the specifics around data management to just some broader comments on this. I think we've discussed pretty well that it's not a subtle shift. And providers, when I try to get their attention, what we're, I'm old enough to practice before we had evaluation and management codes, right? So those came about during my training, where you could do from documenting anything, and it didn't do anything with the reimbursement model, to having to meet certain criteria and certain behaviors to get reimbursed in a fee-for-service world, to now I've likened that shift to going to value-based care is not that, it's that big of a shift of how providers have to change the way they think about information. Downside risk and overhaul of operations, the groups that have embraced this are the ones who do well at it. Trying to retrofit this into a fee-for-service chassis simply doesn't work. Value-based care requires, and this is why you see companies like Curation Health, this is why you see managed service organizations come into this. It requires that, it's funny, anytime you put Epic into a big health system, you're literally creating a software development shop inside a health system, which is strange, and which is why it's pretty difficult. But value-based care requires some sort of data management division within a delivery organization, and a lot of health systems don't have the budget for this kind of talent, or can't attract and retain this kind of talent. So it's one of the things that it's one of our biggest value adds. We have a lot of really bright people and really new, using the latest technology, but we also have a lot of analysts who do a lot of grunt work with data management in order to make this actionable. And that's why a lot of the big organizations are stuck at that 20% barrier that we were talking about, because of a lot of these, sort of internal shifts that you have to make. But also, if I'm an organization, if I'm a CFO, I get my daily census report on my inpatient stay, and I'm making financial decisions based on my current inpatient census. And if you're making if you're planning your organization day by day based on how sick people are, it's really hard to think a year and a half down the road on how well we can make these folks. So this is a lot of things that are currently at a high level currently slowing down the progress of value-based care. Back to this public-private thing, anytime in DC, anytime they say value-based care, I think they mean the ACO REACH program. They mean very particular things, but let's be clear, Medicare Advantage is leading the way. We're halfway to a privatized version of Medicare, and that's increasing every year. They're not a lot of the incentives in Medicare Advantage are I guess there's no cap on that. We talked about the HCCs, we talked about risk adjustment. There's not a cap on that, on how you can do that. So Medicare Advantage is overall it's more expensive. I'll just say it. I'll just say it. Overall, Medicare Advantage is more expensive to provide a more expensive way to provide care for you and for those of us on this call who are paying taxes. Medicare Advantage, it does provide good care. It provides patient engagement in a way that they're used to receiving other services in their lives, but it is more expensive to deliver that care, and we, the taxpayer, are the ones who pay for that balance. Direct contracting was essentially, and one of the rate limiting steps for Medicare Advantage is provisioning, right? Over the years, let's go back to, in the US, we choose to tie our healthcare to our employment. And once you have a retirement age, the payers can no longer go to the head of HR at the company and sign up 40,000 people. So single provisioning is the way you enroll folks in Medicare Advantage. Direct contracting in the old version was an attempt to sign up multiple, thousands of people at a time for a private at-risk entity. That was, and Gil Fillon and Rick, oh my goodness gracious, the piece that he wrote in Health Affairs, and talking to him on the phone a couple of times. He's trying to get me to play golf. I'm not a golfer, Denny.
A good walk spoiled, right?
He wants to talk. He wants to talk about a lot of this stuff while over golf. But the course correction on the direct contracting made it much more aligned with the ACO models and much more conservative. And really took a lot of this out of maybe some private equity hands and put it more into provider group hands. So I think I think it has a lot more. It's just more of a conservative model than because we were with direct contracting the way it was. We were very quickly going to be at 2/3 of a privatized Medicare, and we've kind of slowed that march a little bit with our shift on the DCE. ACO model persists. It's interesting when some of the smartest folks I know and had a pleasure to talk with a lot of them and work with them through the CMMI grant that came about as a part of the Affordable Care Act. And a lot of them have dispersed now to, they're at Optum or they're at some of the big blues, and they're taking a lot of that thought there. ACO model will always be around. It's interesting. They view these as payer experiments. And a 30% success rate for a program that comes out of CMMI, they see as success. If you bat 300, you're in the Hall of Fame. So I think we'll still continue to see payer, provider, quality, and cost containment experiments coming out of the ACO model. I think value-based care is going to be accelerated, but the subscription model is going to be accelerated by the pandemic. I think a lot of folks saw that as a good way to weather that storm, and so I think we're going to see that. And we've seen it in our business. We've seen it accelerate folks moving to value-based care contracting and not really having the infrastructure or the expertise to do it, and we've been helping them a lot with that. When we talk to academics, it's still a myth. It's looking at it this way. So it's interesting too. providers aren't getting a lot of training in this, unless you train at Kaiser, unless you train at Geisinger. Providers are not coming out of their training with a lot of value-based care skills. And I think that's something that we'll see shift. And then the last one, disruption of primary care, the decentralization of primary care, virtual primary care, in-home primary care. It's remarkable. And I'm pointing to the convention hall, just down here in Miami, at the amount of discussion and the amount of products and services and the investment in disrupting the primary care model to take it in other places, whether it be virtual or in the home. And I can't see in my lifetime, I can't see take a day off, go to my primary care provider in brick and mortar, and then whatever follow-up comes of that. I just can't see that model persisting in my lifetime. I think we're going to there's so much investment and so much emphasis on that, that I think we're going to see that move forward.
Do you see, Matt, the No Surprises Act as a way to move folks to value-based care faster?
Hadn't thought of that, Denny.
It's kind of interesting. I hadn't thought of it either. I saw the question. I thought, let me think. Okay, I've got to share everything with the patient.
Yeah.
I've got to know, and this is a role that physicians haven't necessarily accepted, but it's kind of assumed that part of the encounter is going to be the physician, helping to guide the patient to, appropriate clinical decisions that may not present a huge burden to the patient, especially financial burden. And that's a different way. That doesn't come out of medical training. Let me talk with you about the impact of these choices on your pocketbook, and the fact that I may recommend or refer you to an off-campus service, as an example, that is a lower cost than the one that's provided locally, given that I want you to know what the costs are, and I want you to be able to make an informed decision. There is some elements that bear some similarity, physicians' awareness of cost. In this case, it's the cost to the patient as opposed to the premium, if you will.
Yeah.
And there's some interesting overlaps, but it was an interesting question, and I thought I'd throw it out there.
Yeah, well, a couple sides of this. Open notes, right? That initiative, the patient being able to directly see everything that's documented on a visit. It's interesting that the diagnosis of morbid obesity contributes significantly to the risk score, but we've seen providers reluctant, and it's sometimes just driven off of BMI, right? It's a 1-to-1. If your BMI is this, you have this diagnosis. But we see providers not reluctant to capture that because it's not worth the flack that you might get from a patient reading their note, right, and wondering why in the world you did that. When it comes to the No Surprises Act, and it comes to one of the most bizarre things to me about U.S. healthcare is I don't know of any other industry in the world that has complete. There's no correlation between cost, charge, and reimbursement. And a lot of the No Surprises Act, I think, a lot of that comes from, and I've done before. I've turned the charge, the Spinal Tap reference, right? We've turned the charge master up to 11 on our electronic health record. I mean, that's what you do. You just crank up the charges in the hopes that the reimbursement might get a little bit higher, right? I mean, that's the game in a historical fee for service world. And when those charges get pointed at a patient, usually by mistake, a charge from a health system was never intended to go directly to the patient. It's directed to go to a payer who's going to pay whatever they think the service is worth. So I don't know. I think cost is a better marker, but it's just I'll have to think about that a little bit more. But getting better aligned on cost, charges, and reimbursement, I think would do more than
right. Yeah. But the amount that your insurance company is actually going to pay, irrespective of what we charge them, is this. Your copay is that. This is what's going to be left over $300, $3,000, you're on a high deductible health plan, or we can make this choice. I think we're getting close. I think one answer to that, or one tack on that question of no surprises in value-based care, is that we actually are starting to talk about the out-of-pocket cost of the patient.
Yeah.
You know, we're actually saying, forget the charges, forget the charge master is a vestige of older times, and you know it's never going to go down.
Yeah.
But the allowed amount, the reimbursed amount, the patient responsible amount, and whether or not those change based on an informed discussion with a physician is getting us closer to talking about cost. And maybe that's where people will start to see value-based care and no surprises sort of running into each other, which is we're going to stop talking about charges. We're going to stop talking about billable amounts. We're going to start talking about what is the out-of-pocket impact.
Yeah.
You know, so perhaps that's one of the connections.
Yes, no, and I've often learned that unintended consequences are sometimes the most important parts of these really large initiatives. So it'll be interesting to see if we can get around to that.
And there's also, just to add, there's also the requirement in no surprises that services are bundled.
Yeah.
You know, so a patient doesn't have to pick through, then there's recovery, and then there's the room charge, and then there's the anesthesia. There's the requirement that these services start getting bundled. And that's probably a very tight, an essential component in looking at value-based care too, is what is my total exposure as a clinician, as a provider in one of these programs, to the full bundle of services that this patient is going to require. That may be one area of intersection too.
Yeah.
And we could talk about this hypothesize for a long time about it.
Well, and while we're hypothesizing, then I'll bring us back. But one of the things that folks on the program today might also, I recently reviewed the RAND study from the 70s and 80s that really kind of set the for out-of-pocket costs for patients, and it came about copays and deductibles and how all of that came about, and how analyzing that study is almost become an industry in and of itself as well. So to look at that now through how copays and out-of-pocket expenses have only gone up compared to what the guidelines of that study done 40 years ago. I think it's time to rethink a lot of that as well.
Right.
But and just bringing it back to current value-based care, again, merger and acquisition. We talked a little bit about this. Those health systems that are still just trying to get bigger and not better and not coordinate care, it makes it really hard to do value-based care if you're just trying to grow. I don't know what from somebody who's lived in the electronic health record world for now, and seeing it and again, I'm pointing to the conference and the convention hall that I'm at here, seeing all of these siloed solutions that think they can fix this information sharing. It's again, I don't want our interoperability to get more fragmented, but it's we've got to get better here. We just have to get better on how we do this. And it also kind of reminds me of the French model, where a lot of countries have decentralized the patient is the keeper of their data, and your card literally gets swiped every time you go to a provider, and that record stays with you. And I think the decision in this country where we decided to manage it via the meaningful use for all the good that it did, it also has created a lot of these silos right now where there's really no incentives to share more freely. We're getting there with certain legislation and certain incentives, but it's challenging. And then scalable solutions around this. We struggle with this daily. This could have Curation Health on it, on how to manage this data across broader and broader populations, and not lose the integrity. If you want to lose a physician, put a lot of false positives in front of them. If you want to lose them in any sort of any sort of endeavor, let alone value-based care. But this is one that we struggle with daily on how do we get bigger and better at this, but still maintain a certain amount of fidelity and quality of the information that we're sharing. And then a little bit, redundant here from the other slide, but yeah, we're well on the way to privatize Medicare and all the good and bad that comes with that. We've recently dialed back direct contracting a little bit to a more conservative model. I think the subscription model is only going to grow in whatever ways it'll be, especially on Medicare. I think there's not a lot of cost controls built into that Medicare Advantage model, and so I think that's something that we're going to be managing actively over soon that on a national level. And again, the future state primary care, I think it's going to become completely decentralized, and I think that's a really good move. And I think that's a really good way to do it. It's going to think a lot of health systems are going to have to rethink how they're delivering primary care today, because that's a significant part of what they do. But the emphasis on this and the investment in this is really remarkable and very evident from the conference that I'm at.
One question that we have, or point that has been raised by one of our colleagues, is we live in difficult times, politically, culturally. Following COVID, we are confronted with a significant proportion of the population who do not want vaccination recommendations from their provider, who who come into the physician's office armed with reasons and rationales for why they aren't going to do certain things that are in the clinician's mind, if not medically necessary, medically appropriate and supportive to their health. Can you just talk a little bit, Matt, about, as we get into value-based care, as we get into physicians having conversations with patients about the financial impact, there's an element here about educating the population to take care of themselves better. And the irony of showing up at a physician's office with no intention of doing anything the physician is about to tell you is not lost on all of us. But we see, we see this in our culture, and without an informed populace, without a greater understanding, a greater level of health literacy, a lot of this value-based care or shared decision-making or patient engagement is going to become incredibly difficult. Any comments or thoughts about that?
Yeah, well, these are strange days, aren't they? And on the broadest view, just as a country, where your individual freedom meets the common good, we really haven't resolved that.
We're not very good at that. We're not very good at that. Right?
No. Or when your personal freedoms, exact public cost, it's been tough to kind of watch that and live through that. I think it's not that different than a fee for, I'm wearing my ER doctor hat now. Some folks are going to be engaged in their health and some aren't, period, full stop. I think we focus on those that we can engage with. I think there's always that group in the middle, and not to make this sound like a political discussion, but I think there's that group in the middle that you can influence or even incentivize, right? I'm not, when I think of like Matthew Loper's work up in New York City, of sharing per member per month revenue with patients who perform well, I think it's a great model, for a subset of the population who will do that. So no, I think we focus on those who are engaged. We focus on those that we can influence. And then humanity just tells that we have to have that ivermectin discussion again,
Yeah, there's no avoiding the ivermectin, right?
Yeah, but that's, and that's going to be, and it would be interesting to know percentage of your cost drivers are that percentage of those who are not less engaged in their health. I'm sure there's a very high correlation there. But I'm pretty confident I've seen enough populations and seen enough disease burden and cost models across them that this model works if you focus on those who are engaged and you focus on those that you can influence, and then you manage the rest.
Amanda has a great question, and this sort of gnawed at me as we were talking today, which is, when I see all the private equity money flowing into Medicare Advantage, it tells me that we're paying too much for it. And my first reaction is, if private equity sees, a liquidity event that's going to accrue great rewards to the investors, people are paying too much for it. This is a signal of disruption in the Medicare Advantage market. It can't continue to be a place where so much investment capital goes to before the regulators realize it's too rich. The Medicare Advantage reimbursement model or the flexibility accorded to Medicare Advantage payers and providers is too much. Can you comment on that? That strikes me as a place where, if we're going to make value-based care work, there are going to be a lot of unhappy venture capitalists who are going to see what they thought would be the return on an upside only model start getting tamped down. What are your thoughts about that?
Permission to speak freely.
Yes, granted.
So yeah, not only is it more expensive to provide care for those folks, and that bill is passed. I mean, it's the Medicare Advantage organizations are positioned directly between the provider organizations and CMS, and they take those bills and I mean, that's how we got into risk adjustment anyway. The private sector said, we want to insure Medicare, but we can't do it for the rates that the government can. That's all you need to know about a single payer system, right? When they got into, so they pass that up, they mark up those costs, and they keep the lion's share. They share very little of that with the provider organizations. So not only is the model more expensive itself, but what we're seeing right now, and you look back to that Gilfillan article about the valuations of these Medicare Advantage organizations are and they do it per member, or it's evaluated per member or per life, and the valuations per member of those are more than you could ever possibly make off of value-based care. So private equity they're inflating those valuations now. Private equity in healthcare tells me that they will increase these valuations,
raise the prices. Yep.
And they'll sell it to the next entity. I think of HCA, and then I think of like LifePoint, right? HCA builds up health systems, consolidates them, leverages against them, overvaluates them, sells them to LifePoint, and LifePoint does the cost cutting. So we'll have a liquidity event in these Medicare Advantage lives, and then there's going to be a significant cost cutting part. So it's weird, Danny. Right now, the current strategy is waiting on the private equity 7-year cycle to bring costs back down. And in between, who knows what sort of market havoc we're going to have. So costs it has to come down. It has to. We've proven that we can't regulate that down. And so right now we're beholden to the normal PE, private equity and venture capital's curve of inflation and then cost cutting. And I don't know.
It's an unfortunate tide. I mean, it does tell you that what started out as an alternative to fee-for-service Medicare with more choice, but roughly the same cost, is changing. And there has to be, as you've described, a reckoning at some point with overvaluations, overpricing, and the cost cutting that's going to have to come out of these plans.
Yeah.
Well, Matt, this has been a terrific discussion. I'm glad we've had a chance to ask you a lot of questions. I don't know what the weather is like in Florida, but it's a lot better than it is up here, I'm sure. Though it's not bad. It's sunny here, which is a change. Yeah. Give our regards to Vive and to HIMSS. If you're going to HIMSS also, it seems to be the Florida month. And yes. I'm sure some of our participants are at the conference as well. I also want to thank everybody who's joined us today and stayed through our presentation. It was an excellent discussion. I think this is a fascinating topic, Matt, and the perspective you bring to it, having the experience you have, being the physician clinician you are, and understanding that we live in a world where there are countervailing forces to making healthcare work better, faster, cheaper. Some of them are good forces. Some of them have to do with recognizing inequities and disabilities and the needed accommodations and the things that people who fall outside the curve need to get taken care of. But also the fact that we're starting to understand what that curve is and how do we begin to lower the height of that curve and bring more people under it is an effort that most doctors, most providers haven't been trained to do. But we're getting there. It's sometimes the pace is glacial. Sometimes it feels just a little bit slower than that. But we're getting there, and we're getting there because of folks like you and the work you do. So I want to thank you very much for sharing your thoughts and insights with our community. I want to thank everybody who's joined us today. I think we're done with questions. I'll just double check. Yes, we are done with questions. We're leaving no one's questions unanswered. So Matt, thank you very much. Ladies and gentlemen, thank you for joining us today. And any final word from you, Matt, before we adjourn?
Just a word of thanks. Thanks for the opportunity, and are already looking forward to the next presentation.
We look forward to having another one with you, and we'll start working on that right away. Absolutely. All right, ladies and gentlemen, we're adjourned. Thank you all.
Thank you.